Hello, good evening, everyone. Let us know if you can hear us loud and clear. We are back with Dr. Tsakos, as you can see, and we are happy to be here. Thank you, everyone, for joining. Dr. Tsakos, welcome back. This is your first webinar this year, actually, I think.
Yeah.
So
Hello. Yes, it is. Nice.
it's been a while. I mean, you had a chance to participate in one of our events, Ask Your Doctor, this year. So almost first webinar on my IVF answers, but of course you are a big part of our webinar sessions. So I'm glad that you are back in this kind of session. Thank you everyone for confirming that you can hear us. So we are happy that we are going to discuss this particular topic. As we know, this topic brings lots and lots of questions, and I am here to just simply remind you that we will start with Dr. Tsakos' presentation on IVF or pregnancy after 40. But of course, we know that you are here for the questions most of the time, and that's why Dr. Tsakos is here. And of course, he will be happy to answer any of your questions. So, as always, put those in the chat so that we can take care of those right after the presentation. And yeah, I think we can start our presentation. Dr. Tsakos, are you ready to begin our session today?
Yeah, sure. Absolutely. I mean, it's 7 minutes past 9 in the evening in Greece. It's been a wonderful day. Long day. Started at 7 in the morning for us at the Embryoclinic, and has
Okay.
yeah.
Busy
So
day.
full of energy and full of positive vibes from wonderful results we had all day and amazing patients arriving from everywhere. I can see a hello from Canada. We have a wonderful Canadian couple at the moment in our clinic. So
Okay.
thank you so much, and hi Serbia. I mean, it's always nice to know who is listening in.
Paris, we also
So
have. So,
so please let's fire away. So I will make it short and sweet so that we have more time for questions and personalized advice. And looking forward to just interacting with Argentina. Hi, Argentina, Sergio. So please, let me start if I may.
yes, let's go ahead. Thank you so much, everyone, for joining. I'm sure it's going to be a great session. You can type the questions right now or later on during the Q&A. And let's go ahead with the presentation first. Thank you.
Okay, sure. So IVF after the age of 40. I'm very familiar with this topic because I used to do it maybe 15, 20 years ago for IVF after the age of 35. And I'm pretty sure I promise you to be around in a few years and put the landmark, put the milestone even further to 45. So the age of 40 is a very young age for women. We know that very well. And we know that someone can be very healthy in the 40s, mid 40s, late 40s, and early 50s in order to carry a baby. So I'm very much for that. I mean, at the moment, the age limit in Greece has gone up from 50 years for the female age to 54. Of course, there are some specific requirements before we can accept women for that. And number one is safety. And I can proudly share with you that at the moment we have 3 ladies over the age of 50 pregnant. One is actually 54 and a bit. She was successful with her first attempt just before she turned 54, which is the upper age limit in Greece, plus another 2 women in the early 50s. So I would definitely say that it's never late. If someone is willing and motivated and wishing to become parents, despite the slightly advanced maternal or paternal age, it can happen. But of course, it doesn't happen without without risks and challenges. And I'm here to try and clarify those. And of course, I will give you an IVF guide for women over 40. What are the options for women over 40, and what is pregnancy like over the age of 40? So, fertility after 40. I mean, it's becoming increasingly common, either for women for the first family or the first baby, or women for second family, second baby, or even more. I mean, we very often, I mean, recently today, actually, I had a request from Sweden for a couple in the early 40s who already have 2 children and they want more. So the right to parenthood is here, and we are here to be able to support that. And of course, making sure that we empower you with knowledge, with evidence, and with our passion which is mostly derived from your passion. It's a two-way thing. So increasingly common, higher prevalence of infertility, of course, lower chance of conception. We know all that. And risk of adverse outcomes. We know all that. Why is it happening? Why, why is that milestone fairly important? Because of genetic abnormalities. We know that. Because of diminishing fertility. And fertility is not just ovaries. It's the tubes, it's the environment, it's the peritoneum, it's the potential fibroids. I mean, fibroids are very common in women over 40. How common? Maybe half of women over 40 may have fibroids. And of course, the risks, the increased maternal risks associated with pregnancy and fertility treatment. So all of those factors, they result into lower success of any interventions we do and higher risk. So what happens? There's less number of eggs, quantity, ovarian reserve. There's less quality of eggs, quality, we know that. There's less overall fertility. You can see the graphs here, how it declines, but it doesn't disappear, it doesn't diminish. And we're talking here both about natural fertility and, of course, of assisted fertility. And there's increased risk of miscarriage. So these are the main effects of aging on reproductive outcomes related to maternal age. And of course, a big proportion of those adverse outcomes are genetic abnormalities. I mean, in simple terms, the ability of the egg, of the fertilized egg to divide becomes less with advanced female age and paternal age, of course. The age of the man is important as well. Let's not forget that. Although the legislation doesn't prevent a man, at least in Greece, in his 70s, 80s, or even 90s, to father a child. And so the legislation is a little bit unfair on women. It's always been the case. And I think we're here to advocate for our patients and for our female patients and for our couples. So we know all that, but we also know that there are ways to overcome those hurdles. And I will try to explain in simple terms which are those ways. Hi, Johannesburg. You're on my to visit list, and hopefully I will be blessed to visit your beautiful country one day. So, general health concerns: breast cancer, hypertension, cardiovascular risks, diabetes and obesity, congenital anomalies, cervical issues, uterine dysfunction, the effects of the lifestyle factors, and of course the obstetric risk. But we know all that. And, all we're called to do is quantify those factors for the individual patients. What are the obstetric risks? Mortality, congenital anomalies, miscarriages, stillbirths, premature births, ectopic pregnancies, and preeclampsia. So what is the guide? I mean, we know it's a tricky road. We know it's a difficult journey. But having said that, medicine of 2024 is empowered with more knowledge, more evidence, more technology, more support, more understanding, better psychology support, better counseling, and all that. So we are getting better as well. Firstly, to understand and acknowledge the importance of being there for those patients. I mean, if I want to resemble, medicine can be complex as well, whether it's cardiology, ejecting women in their 40s or late 40s or early 50s on the basis of the age alone is like rejecting a cardiology patient in the 80s just because they've gone past the life expectancy. And I think it's unfair, especially for the individual patient. It's seriously unfair. We're here to advocate for that. So fertility treatment, what do? We do all the pre-IVF testing and counseling. This is the wonderful team of my embryologist. There's a fourth embryologist listening in, Mr. Dave Gibbon, who is the soul of Embryoclinic, always there, always present, always supportive, and always contributing in more ways than one in what we have achieved over the years. So pre-IVF testing, very important. There's a lot of patients perhaps wishing to cut corners, wishing to move on. A lot of stressed patients believing that maybe a month or 2 or 3 would make a huge difference in the ovarian reserve or in the outcome of IVF. And, we take a little bit of a time to convince and educate and support and empower our patients about the importance of pre-IVF testing. It's very important. Just like, no player, Lionel Messi, he needs coaching before entering the pits. So similarly, our patients, I think it's unfair to see them today and start stimulation tomorrow or in a couple of weeks. I think we need time to know more about them. We need time to evaluate safety, risks, and this doesn't just apply to women over 40, applies to everyone. And then we have IVF and ICSI, a lot of opportunity to prepare and achieve fertilization. We have the option of oocyte or embryo donation, and we also have the option of surrogacy program. So during this pre-IVF testing and assessment, and in my clinic, we offer at least a free Skype to start with, a free initial assessment of every individual case in order to be able to give them a little bit of knowledge and a little bit of evidence of what they need. So what is pre-IVF testing? It's all the standard stuff. Most people know this and most people do them, like AMH testing, female hormones, thyroid, etc. Is the viral screening and infectious disease screening, the vaginal swabs, is the scanning, ultrasound scanning, but also it may involve some direct anatomy assessment. We got better in scans. Maybe 20 years ago, the scanning technology was not as advanced as it is now, but it's still not the gold standard. I mean, the gold standard for evaluating the endometrium remains the hysteroscopy, and sometimes together with biopsy, plus or minus microbiome testing. Fallopian tube patency, very important, not just in the preliminary stages of investigation, but also in advanced stages. I mean, I get asked many times because many people, perhaps many clinicians, they don't value very much the importance of the environment, the importance of getting some knowledge. Okay, we're good in the lab, but we also need a good field. We need a good soil when we implant. And apart from the soil itself, the surrounding soil is also important. I mean, excluding hydrosalpinx is very important. Excluding endometriosis as much as we can without laparoscopy or MRI is important as well. The endometrial microbiome, that's a new kid on the block. It's been around for, I don't know, maybe 5-6 years now in everyday clinical practice. It is providing us with some information, maybe not for the patient who's starting first time or second time, but maybe for complex cases that have been unsuccessful. It's a good piece of information that we utilize in order to improve the pregnancy success and the pregnancy outcome. And of course, genetic testing is very important as well. It's very unfair for patients to undergo IVF and only find out after 2 or 3 failures that they have a karyotype, a DNA problem. Very unfair. And certainly in our unit, this karyotype and cystic fibrosis testing is amongst the absolutely essential tests that we suggest. Now, IVF and ICSI, a lot of ways to do that on a natural cycle, on a mildly stimulated cycle, on a conventional cycle. And of course, we know only too well that multiple transfers may be needed. So just like some treatments like, I don't know, treatments that need a series, like physiotherapy that needs a package, or like acupuncture that you're not expecting to see an effect unless you have a series of tests and all that. Equally, IVF, in my opinion, has to be seen, has to be viewed as a journey. I mean, it's not one treatment; it's perhaps a package of treatments, and the cumulative chance of pregnancy, the overall chances of pregnancy, is increased by the number of transfers we do. In my opinion, I have a very certain view on this. I mean, every time, okay, if it's a natural cycle, yeah, we expect one egg. But if it's a mild or conventional IVF, my aim is to get as many eggs as possible, as good quality eggs as possible, by optimizing the stimulation protocol, the timing of trigger, and the perfect egg collection. That in those patients may make a difference between, there's a huge difference between getting 2 eggs and 3 eggs. That's a huge difference, and also between 3 eggs and 4 eggs. So every egg counts, because that may give us the valuable embryo that will achieve pregnancy. So what about aneuploidy? We know that the chance, aneuploidy is a scientific term to describe abnormal chromosomes, abnormal DNA on the embryo, and of course we can overcome that with either PGTA testing or oocyte and embryo donation. PGTA testing, straightforward, taking a biopsy of the blastocyst, usually the day 5 embryo, we send it off for diagnosis, and then we get back what we call normal, either normal embryos or abnormal embryos, black or white. Sometimes we get gray embryos, but even then, there's a lot of ways to understand if it's light gray or if it's dark gray. So a lot of information for the embryo prior to embryo transfer. And of course, there's a lot of benefits on PGTA. PGTA is not for everyone, but we're talking here about women over the age of 40. In my opinion, there's a huge value of PGTA for women over 40. Of course, still not for everyone, but it should be discussed on individual basis. It improves per embryo transfer the chance of success. Of course, we always have the possibility of a no embryo transfer, no transfer, which can be devastating for everyone. But at least we know the truth before we've subjected our patients to 3 weeks of medical treatment and stress and all that can be avoided by knowing at an early stage that we don't have a suitable embryo for transfer. Reduced miscarriage rates, reduced of the delay to ongoing pregnancy, much less risk of abnormalities, the opportunity to perform single embryo transfer, and the reduction in multiple pregnancy rates. So a PGTA tested embryo is much more valuable than a non-PGTA tested embryo, certainly after a certain age, which is the age of 40. And of course, there's the option of oocyte and embryo donation. I'm not going to go into this in much detail, but we know only too well that having tried with their own eggs, women who have reached maybe the age of 45, then the chance of achieving a pregnancy with their own eggs is seriously low. And this is the time when oocyte and embryo donation may be an option. And of course, gestational surrogacy. With gestational surrogacy, we may overcome 2 limiting factors. One is that of the uterus. It's indicated in the absolute uterine factor in fertility. So is uterine transplantation, of course, and I'm not going to say too much about it, but I foresee that following the progress in the uterine transplantation field of the last 10 years, with the pioneering teams of Sweden who started, and then other teams who started all over the world, we are here in a position where more than 100 cases have been successfully performed all over the world, with an overall chance of pregnancy of over 8%. So I'm not going to mention much about uterine transplantation. I have to share with you, however, that this is my passion at the moment, and I'm very blessed, fortunate, and privileged to be talking with world's best in order to see if this program could become a reality not very far from home. I think that's all I can say for now. Until then, gestational surrogacy is the everyday, clinically applied solution for absolute uterine factor infertility. And of course, this can always be combined with oocyte and egg donation and embryo donation as well. So advanced fertility options for women over that. This is again a new kid on the block, platelet-rich plasma. Most of you may have been in touch with this technology or have known this technology. Some of you may have asked me about this technology in the last few years. Now I have to share with you that it seems that the evidence is there that platelet-rich plasma treatments may be beneficial, definitely for uterine factors and maybe for ovarian factors. I'm very specific. For uterine factors, there seems to be a very good effect on the improvement of the uterine ability to accept a pregnancy, with scientific evidence now that it may reduce miscarriage by 50%, implantation increase 6%, higher pregnancy rate and higher delivery rates. There's two wonderful meta-analyses that we've included, and they actually ignited our program at Embryoclinic, which started a few months ago for endometrial PRP treatment. It's not for everyone. It's not for every woman just on the basis of how old they are. We're very selective. There's a lot of counseling involved. Usually, we suggest that on women with some sort of uterine injury in the past, either through miscarriage, DNC, hysteroscopy, myomectomy, of course, known anomalies, adhesions, diaphragms that have been treated and corrected surgically, or multiple failures may be associated with thin endometrium. So there are specific indications to which we're very happy to counsel our patients. Now, ovarian rejuvenation, ovarian PRP, for those who are not very familiar, PRP stands for platelet-rich plasma. So we take patients' own blood. We need a good amount of this of the blood in the region of 20 to 25 mL, and then we work on this in order to isolate high concentration of platelets. There's a lot of tricks there. There's a lot of areas that our lab has worked on. A very important piece of information here is that although in general, especially for orthopedics, the density and the concentration of platelets is enough if it's up to 300,000 per microliter. In fertility, we need at least 1 million per microliter. So we need a much higher concentration. We need to have quality controls. We need to have aseptic techniques. This has to be performed within laminar flows, within our lab, ensure that it's sterile. And of course, in our program, we ensure that every single time we apply PRP, we know exactly where we're injecting by doing quality control on the sample and by quantifying the concentration of platelets, and also by doing cultures to ensure that this is free of germs. So it's not as easy as it sounds, but if it's performed in an optimal manner, it is another additional treatment that may enhance fertility for this specific group of patients. Now, ovarian rejuvenation, there's been lots of studies. I mean, the most recent one that we are based upon is this by Tulek, which showed that in poor responder, in reproductively older, I hate this word older, but reproductively advanced maternal age patients, it may improve the yield of oocytes, the number of embryos created and all that. In his study, he failed to show better results in terms of life, statistically better, although there is a trend towards that. I think there's a lot of diversity in how this treatment is being performed. I think it needs a little bit of optimization. We need to understand which is the best subgroup of patients, and we need with the best value, and we need to standardize our technique. And by all means, I'm very happy to discuss further individually. Now, hysteroscopy, I'm a big fan of hysteroscopy. In my times, in my training years in England, in Bristol, in Norwich, Newcastle in the early 90s, early to mid 90s, no one would go through IVF without prior hysteroscopy, because we didn't want to waste the few resources of IVF we had on a uterus that hasn't been tested. Hysteroscopy has a specific value in place, and we should not forget that. Also, we should not forget that over 40, the chance of an anomaly is even higher. So we need to ensure that we're implanting in a normal, healthy endometrium. And although extremely rare, 1 in 500 women, let's not forget, with fibroid in this age group may have a malignancy. And we need to make sure that we implant in a healthy uterus. Okay, I'm only going to be 10 more minutes. So robotic surgery, again, it's one of my passions, because it combines my core training, which is surgery. I was a surgeon before I moved on to IVF, and thanks to my wonderful team, I maintain a surgeon's heart, because I feel that surgery has a lot to offer still, and robotic surgery is this perfect example. This is our study on the benefits, our own publication from our team on the benefits of robotic surgery in improving fertility outcomes when treating myomas. So there's a huge place in that. So what about pregnancy? We've done all the pre-IVF, we've done the counseling, we've done the treatments, we've done the add-ons, and the woman is pregnant. What is she to expect? Okay, we know that the risk is higher for most obstetrical complications. However, we know that this is a reality. We know that after the climate change, global fertility drop, global infertility, global demographics is the next world crisis. And the projection is that we have reached the world's top number population, which is in the region of 8 billion, but this will begin to drop. And this is a global thing. It's not just in Greece, which has the lowest, excuse me, the lowest fertility rates in Europe, 1.2 children per woman. In Greece, since 2010, there is, in a population of 10 million, we have 40,000 births less per year. So in the last 13 years, there's been about 500,000 less children born in Greece. But nowhere in Europe, in England, as far as I know, the fertility rate is somewhere in 1.7, 1.6. It's still very low. There's no country in Europe with a fertility rate above 2.1, which is the minimum rate in order to sustain the population. So demographics, the demographic crisis is the next crisis that our world will be faced with. So if we exclude the women over 40, then things are even worse. And of course, some of you have experienced the rejection from the public system. That's another political discussion that I don't want to get into. I think it's very, very unfair. I think it's very unfair and not realizing, not accepting, not addressing, and not supporting fertility as a disease. But anyway, it's too late for politics, especially tonight. So pregnancy over the age of 40 is becoming increasingly prevalent. We know that. There's a lot of ways to prevent and make it better. Obstetric care has to be better. It has to be more intense. It has to be more successful. It has to be more safe. So, and it can be very safe. Take-home messages. Pregnancies at 40 plus is increasingly common, particularly in the context of ART. In my clinic, the average age of the female age for IVF is 38 and a half. So just to give you an example, the average. Women of advanced age, we know they have less fertility and higher risk. However, there's a lot of options and a lot of individual indications. There's a huge number of advanced options as well. And our commitment to all of you is that we keep following the data, following the scientific evidence. And whenever there is scientific evidence that we have available treatments for all of you, and close monitoring and adherence to medical protocols and instructions can ensure that in the vast majority of cases, not only are we going to achieve a positive outcome, but we're going to do it safely. This is the literature for those of you who want to look into the original papers. At this stage, I would like to thank all of my team because they back me up when I prepare this presentation. They back me up every single time I go away to learn a new technique, or I spend 7 hours in the operating theater with complex myomectomies and complex endometriosis surgeries. Especially for this presentation, a special thanks to this bright new doctor, Dr. Manos Xidias. Look out for this name. I think this guy is going to be world famous in the next few years. I'm sure about this, and it's been an honor and privilege to have him working with us in the last couple of years. So thank you all, and I'm free to take questions for the next 25 minutes. Thank you.
Great. Thank you so much, Dr. Tsakos. As always, great presentation. Lots of details, but now your favorite part, we will go straight to your questions. As you can see, plenty of questions are right here. So let me go through them one by one. And let me have a look at the first one from Lou. So many thanks for this conference. I am from Berlin, 41. IVF with my own ex oocyte did not work. My question is, so is treatment in Greece or Cyprus possible for a single woman? I'm interested in double donation. What information is available about donors? Could I choose them myself? What is maximal age of a donor?
Okay, sure. Hi, thank you very much, Lou. Lots of questions. I mean, yeah, definitely embryo donation is an option for you. It's legal and regulated in Greece. It's anonymous, so you can be given anonymous information. Anonymous is anything that's non-identifying the donor, so you can have the age, the characteristic, blood groups, all the screening we usually do. Very elaborate screening and so forth. Now, the upper age limit for female donors is 35. Having said that, in my clinic, we have set a limit of 32, and most of our actually female egg donors are in their 20s, so that's the upper age limit. So it's a very successful program. Having said that, one of the prerequisites is that you're healthy, you have your pre-IVF screening, your uterus is healthy, you're in good shape and all that. And of course, that has to be assessed thoroughly before the embryo transfer. I mean, as a protocol, as a rule, in my clinic and in my practice is that if someone is within 3 to 4 hours flight, 5 hours flight, I strongly recommend an initial visit to any clinic before you commit to treatment. This is giving everyone the opportunity to discuss, to speak, to ask questions, to counsel, to get a feeling of the clinic prior to committing to such an important endeavor. I know that everybody's time is precious, but I think a pre-IVF visit is very important, not only to ensure success, but also to ensure quality, safety, and a good experience. You can imagine if someone visits just once to have the embryo transfer, you have all the added stress of various factors that can be eliminated with 2 visits. So I hope I have answered.
Thanks a lot, of course, for your first question. And then we'll go straight to the question. Actually, it's not a follow-up, but the second question from the same patient. Okay, so let me just read it for you. So do you recommend a long protocol for stimulation for 40 plus and poor responder? I have only one oocyte, regardless of whether with medicine, hormones, within a short protocol or without.
To be honest, let me tell you a personal story. I mean, we've all started with a long protocol because that was all there was. And then the short antagonist protocol came out in the early 2000s. And most of us, including myself, we took quite a few years to familiarize ourselves. And, you don't change in IVF very easily, especially if something has been working and all that. To cut the long story short, I think now that, there's very few people perhaps, and there's very few real indication for the long protocol. So definitely in your case, I would not use the long protocol. I would use the short protocol. And I think the fine-tuning thing would be whether it would be mild stimulation, it would be a combination of perhaps a tablet with FSH injections, or whether it would be a completely natural cycle. So definitely not a long protocol in your case.
Okay, thank you so much for your questions as well. And we will go now to the next one. So, is karyotype testing required where donor egg is going to be used to create the embryo?
No, female, no. If we're using egg donation, if we're using egg donation, female karyotype is not needed.
Mhm.
Male karyotype, in my opinion, is needed, and of course, the female egg donor, they have a karyotype test.
Okay.
So in my opinion, karyotype is part of the essential investigations, in my opinion. Firstly, because now it's become fairly inexpensive. I mean, in the old times, 15, 20 years ago, it used to cost, thousands of euros. Now it's in the hundreds, in the few hundreds, especially in Europe. Perhaps in the US is much more. But I think for any fertility couple, firstly, it's one-off test, so you do it once and it's valid forever. And then, the chance of having abnormal karyotype unexpectedly, in my practice, is about 2%, which is not negligible. 2%, that's probably in my unit, maybe, I don't know, 12, 15 patients a year. That's probably one a month who would have IVF with no hope of success, only to find out a couple of years later that problem. So, okay, the 2% may not sound huge, but I think for the individual patient and in the context of IVF is pretty important. So, anyone who's providing genetic material, in my opinion, should undergo karyotype testing.
Crystal clear. Thank you so much. As you can see, lots of things are going on in the chat. But let me go to the next question from Camila. In regards to testing, what is your opinion about receptivity tests? I hear different opinions. That is a must to do before starting IVF, and others are saying that is not a very conclusive test. What can you say?
To be honest, Camila, again, I will tell you my opinion. I mean, I was never convinced with the testing, and I've never ever performed it myself because I was, to my patients, of course, because I was never convinced and scientifically convinced. I mean, we all try to keep an open mind, but sometimes it just doesn't work. I think that now the scientific evidence is out, very clearly out, that it's not helpful. So I do not suggest it.
Mm-hmm. Okay, thank you for that again as well. Anita would like to know, so I will be 42 next month. I have done 2 follicular count scans. One last month showed a total of 7 follicles. A second one today showed a total of 16 follicles. Is this normal? Does the number of follicles vary a lot from month to the other one?
Sure. Okay. I mean, Anita, I'm sorry, it's our fault. Doctors, we haven't decided yet. We haven't agreed between ourselves what we count as follicles. As you probably know, a follicle could measure from 2 millimeters to 9 millimeters. The question is, which ones do we consider follicles? What size? And of course, sometimes we measure twice the same follicle. Depending on the day, sometimes we're over optimistic, some others we're over optimistic. And then it has to do with the scanning machine we use and so forth. So that's why the counting of the follicles, which is defined as antral follicle count, AFC, is very subjective and maybe not very accurate. More accurate is the AMH testing. I would have thought that at the age of 42 is extremely unlikely that you have 16 follicles. And if you do, you probably have polycystic ovaries. Now, to cover this gap, now we have artificial intelligence. And hopefully, we have some sort of software. Actually, we have it in our unit. So if we're in doubt, we let the computer, we let the software decide how many follicles you have. Even that is not 100% accurate, but sometimes it's a little bit better than us. I feel that in the next couple of years, that will be the norm everywhere. You will have the probe inserted, and then it would be like artificial intelligence measuring by predefining parameters of maybe follicles between 3 and 7 millimeters, how many follicles you have. If you want to solve the mystery, I'm not going to ask you to have yet another scan. I would just ask you to have an AMH test. I think AMH, my team, we proudly contributed in all the creation of science and knowledge on AMH value and the comparison of AMH and AHC by doing a couple of wonderful studies in the late 2000, 2009, 2011. And actually our studies are included in the European Society guidelines, ESHRE guidelines. And we found that perhaps AMH is more reliable because it's less operator dependent. So clearly have an AMH test. And then, of course, the AMH has to be evaluated, has to be assessed based on your age. There's specific graphs to show you how you relate in other women in your age group. But even that, in my opinion, is not as important as it is to see how, for yourself, what is the function of your ovaries. In my opinion, the best test of ovarian reserve is a stimulation. Because if you have optimal stimulation and properly designed and monitored stimulation, you will know what is the ability of your ovaries to produce eggs. So AMH and then move on with stimulation, and you will know. In either case, the biggest risk, the biggest fear, the biggest implication of 42 years old on the ovaries is reduced follicular number. Even if we take the 7 follicles number, that's still pretty good going. So go ahead, that would give you a very good chance of pregnancy.
Okay, brilliant. Thank you so much. Now we will go to a bit of a longer question. So let me put this here. So what do you recommend if there is a genetic thrombophilia? So heparin, aspirin therapy after the IVF during pregnancy or anything else with genetic mutation are or could be problematic for pregnancy. I had a miscarriage at 11th week despite of Clexane and aspirin therapy. I have several genetic factors, mutations. Could this be the reason for the miscarriage?
Sure. Absolutely impossible to answer this question. It has to be individualized. If there's thrombophilia, that has to be assessed thoroughly, either by your gynecologist if they feel they're experts in that, or by a hematologist, a blood doctor. Now, miscarriages, of course, can be caused by other factors, not just thrombophilia. That's a difficult one. I can't answer. All I can say is that it has to be individualized. Miscarriages sometimes can be multifactorial. They may be due to various factors, not just to one factor. So all we're trying to do is optimize any finding we may have. So if there is specific thrombophilia, then yes, consult with your hematologist. What is the best combination? It's not just a matter of, sometimes it's a matter of dosage, it's a matter of when to start what, and so forth. Don't forget that the combination of aspirin and heparin sometimes may have adverse effects, so it's not easy to answer. And if you want to eliminate the risks of miscarriages, and especially if you're over 40, maybe PGTA testing will ensure that at least you have excluded genetic factors for miscarriages.
Okay, again, thanks a lot. Now we will go to a question about PRP. So after how many months do you observe a good result after ovarian PRP? How do you measure ovarian PRP result via lower FSH, a higher MH? For how long do you observe any improvement that you could achieve after PRP? How often do you recommend to try it? I had ovarian PRP twice, but the result, better FSH and better AMH, came only after 5 cycles. Is it still within the range? Should I repeat it again?
Thank you so much for your questions. We wonder the same thing, to be honest. It's a treatment that is not fully standardized yet. There's a lot of factors unknown, even in the papers that, people publish. As I said, we don't know what they inject. Most people, do they inject 500,000 platelets per microliter or 4 million? We don't know that. How do we inject it? Yeah, some people do it vaginally. Okay, vaginally, do you do it deep into the medulla? Do you do it just under the cortex? It's not standardized. All I can say is that the effect depends on how you define a good effect. I mean, for me, it's not a matter of seeing better number on the lab report. It's a matter of seeing follicles on the scan, and even more, a matter of seeing good quality eggs on the egg collection. So I think having done 2 PRPs, I don't know if you know the concentration of platelets that you were injected. I think 5 or 6 months is probably the maximum I would wait. If there's no effect, I would probably call it a day. I wouldn't try more. Now, with regards to the endometrium, I would start with a simple injection, which is like an IUI, and then I would observe the result. Of course, the result could be either visible on scan or on Dopplers, the thickness, the quality of the endometrium, the layers, the trilaminar appearance, so forth, and the Doppler studies. We're hoping that new biomarkers of the endometrium will be developed. So, if in general you have a satisfying endometrium, I wouldn't suggest the hysteroscopic injection. I would only suggest if maybe after a couple of injections it doesn't work. But in my opinion, there is a bit of a better value of injecting PRP a few days prior to the embryo transfer.
Perfect. Thank you so much. Next question, a bit of a longer question, one details. So let's have a look. Okay. I had done my first IVF at 42, got 9 eggs, ended up with 2 untested embryos. I am planning to transfer in the next 2 months. And as you can see the details here, my question, do you do priming in women over 40? What are they? Any suggestion on key factors to success on implantation from medical intervention? As you can see, more questions, but if you can have a look and perhaps advise.
I mean, priming I don't do. I don't like priming because I feel that, to put in simple terms, it puts the ovaries to sleep, it downregulates the ovaries, and then you require higher dose. Priming, I think there's pretty good evidence that probably reduces the overall chance of pregnancy by maybe 5%. Of course, sometimes, we have to do it in order to fit into the schedule of the patients, sometimes schedule of the clinics, of the doctor, I'm not a big fan of priming. To be honest, I don't do it. Of course, depends on what you define. I mean, most people by saying priming, they mean how do they prepare the ovaries. I believe in DHEA, although some studies are contradicting, but I think, there's nothing to be lost with DHEA priming, not with manipulating with downregulation or with a pill. And untested embryos, 2 embryos untested, if they're good quality, go for it. I think you can expect a good outcome. Now, human growth hormone, there's no evidence that it helps. I was tempted to use it many times, and I never did personally after 30 plus years on the job. So there's no evidence. I'm not convinced. It's expensive. It may have some side effects. I'm not really convinced scientifically. What other questions? Change of protocol from cycle to cycle. Look, if you get 2 embryos at 42, I would stick to that protocol. I mean, I think that's probably 2 good quality embryos is probably the maximum someone could expect. Take a month off after PRP. It depends on what PRP you mean. I mean, ovarian PRP, yes, I would take a couple of months, 2 to 3 months off. If it's uterine PRP, as I said before, I think, in our protocols, we use it within the treatment cycle because it seems that the growth factors are fairly important if they're there during implantations. That's it. I think I've answered most of them, Catherine.
Brilliant. Thank you so much indeed. Of course, lots of questions within one. We still have a few minutes, so let me go to the next question from Anita this time. When would you suggest to do hysteroscopy during the cycle? 5th day, 9th day? Is the 10th day too late?
No, it doesn't matter. In my opinion, it doesn't matter. It's never too late. Depends. Depends. I mean, yeah,
Mhm.
if I can time it, just remember that timing, is not always possible. If I can time it, if I would time it, I would probably prefer any time between 7 and, I don't know, 13
Mhm.
days of the cycle. But it's not possible to time it all the time. So I don't think I mean, the only issue usually is the risk of pregnancy and making sure that someone is not pregnant when you're doing it. Otherwise, I don't think it makes a huge difference. And sometimes timing can be very stressful for patients, for the clinics, and all that. So yeah, I mean, as long as someone is not on a period and is not pregnant, I'm happy to perform it.
Sounds about right then. So, what do you suggest for someone that has thin lining? I've tried estrogen, but it doesn't help thickening my lining. This problem has caused a 5 cancelled rounds of IVF. I'm 44.
Yeah, it depends on the definition of thin lining. And in my opinion, of course, the size, the depth, the width of the endometrium is important, but also the shape is important, and the consistency, the quality, and all that. And is that what is the hysteroscopy? What does the hysteroscopy look like with thin endometrium? Is it atrophic? Is it adhesions? Is it what is it? So, I like, thin endometrium doesn't mean much unless we have clarified what is it caused by. Of course, the most, the commonest cause of thin endometrium is adhesions or previous miscarriages or inflammation or some sort of lacking of normal glands. I don't think we have a lot. And how do you define it? I mean, most people define thin endometrium under 7 millimeters. I mean, some of our patients with 8.5 millimeter, the word it's thin. So, we have to define it as well. I mean, in my opinion, thin endometrium is under 8 when you do embryo transfer, and very thin endometrium is between, 6 and 7ish. And of course, under 6, it's very difficult endometrium. I think that I would do my microbiology testing, hysteroscopy, biopsy, microbiome testing, and then I think in terms of preparation, we need pretty large dosage of estrogens, perhaps with different modes of administration, oral, vaginal, and transdermal patches. I'm a big fan of Viagra. Viagra in order to improve the quality of the endometrium, and then PRP. I think these are the weapons we can use.
Hmm? Okay.
Sometimes we may need to repeat PRP twice during the cycle. So in a stimulation cycle or in a frozen embryo transfer cycle, I would perhaps perform the first PRP on cycle day 7 or 8, and maybe the second PRP for 3 to 4 days prior to embryo transfer.
Okay. And let's go to a different question here. For women with Asherman syndrome treated with hysteroscopy but still having thin lining, do you think a modified cycle would be more beneficial than a fully medicated cycle?
I don't know, to be honest. I have no answer to that. Uh,
Mm.
the main reason of thin endometrium is not the estrogens, is the fact that there's no receptors, there's no healthy tissue. It's like trying, in a football pitch, just trying to grow grass where the goalkeeper is. I mean, it's very difficult to grow grass there. In my opinion, it doesn't make a huge difference. I would definitely supplement um, with external estrogens, and I would definitely consider PRP. We don't have very much more as an option. I mean, please remember that, before hysteroscopy, Asherman syndrome was the end of the road for the patients carrying their own child, and surrogacy was the only option. So I think our weapons are these: hysteroscopy, adhesiolysis, repeat hysteroscopy, maybe a couple of times, estrogens, big dose of estrogens, Viagra, and PRP, and
Okay.
exclusion of infections, either by simple microbiology testing, or even better with microbiome testing. So we have about 10 options here.
Okay, thank you so much. And we
Can
will
I
go.
take one more question, please?
Yes, exactly. That's what I wanted to say.
By all means, I can type our email. And by
Sure,
all means,
let's
I
do that.
promise if you quote IVF answers, I will
Maya
answer,
defenses, yeah.
and I
Sure.
will offer you free Skype as well. So if you, I will write my the clinic's email,
Mhm.
and one of our coordinators will pick it up.
That sounds good.
info@embryoclinic.eu. So one more question, please.
Yes, definitely. This will be the final question for today. But as Dr. Tsakos mentioned, you can just get in touch with the team directly. I'm sure they will be happy to help you out. And so the question that I see here, so what to do in case of low ovarian reserve and on top of that, low response to stimulation?
Okay. Yeah, I try to define successful outcome. So if someone has an ovarian reserve of maybe 2, 3 follicles, my successful outcome is to get at least 2 eggs. So I try to achieve that with the most clever way, and in my opinion, the most clever way is to get those 2 eggs with the lower possible uh, amount of drugs. I find so I try all sorts of different protocols. I mean, I'm not a big fan of big dosage. I mean, I hardly never use more than 300. I don't think there's much scope there. 350 maybe absolute maximum. I know that many people use 450, which yeah may give us temporary joy by getting perhaps one extra egg, but then we find that this egg is not such good quality. So yeah, I don't go beyond that. I mean, how do I treat that? So I try to diagnose a potential low response or potential low yield before stimulation. So low AMH, an AFC of 3 in a 42-year-old. Okay, fine. I do full stimulation first cycle, unless she's done it before somewhere else. Yeah. So full stimulation, 300 units, 350 if maybe the lady is more than 90 kilos, 85 to 90 kilos. But this is where I stop. I don't go beyond 350. And it's kilos more than BMI. Then I see what I get. If I get 2 to 3 eggs, I'm happy. Good quality eggs, I'm fine. I'm happy. If I create 1, 2 embryos, I'm happy. I know this is successful outcome. If I get 1 egg, I'm not happy, even if I get 1 embryo. Because if I get 1 egg, the second stimulation I would do mild stimulation. So 150 units plus minus letrozole or clomiphene. In my experience, clomiphene and letrozole, they have different modes of action. I don't very often use them together, but I have done. They have different mode of action, the tablets to the injection. So I try to utilize different modes of action to stimulate the ovaries. If I still get 1 egg with the modified natural or with the mild stimulation, then I go for mild. Then I go for natural cycles. That's what I do.
Okay. Thank you so much. As you can see, lots of questions, and this was a great session indeed. As you can see, there are also lots of comments coming up your way with thanks. Definitely great presentation, and everyone, I guess you are quite satisfied with how it went today. I'm really happy that we were able to discuss this topic, and that you had so many questions. We were not able to answer all of them, but of course, as Dr. Tsakos mentioned, you can get in touch with the team. I'm sure they will be happy to help you out, and Dr. Tsakos himself as well. So thank you everyone for today. And I also want to encourage anyone to simply go to our survey right after we finish. You will be redirected to the page. So please let us know what is your opinion about this session. And this is just so we can improve. So just share your feedback. We will be happy to receive it. Dr. Tsakos, always a pleasure. I'm so glad to see you back here. And of course, we are definitely looking forward for some more events. I know there are some already scheduled, so looking forward to it. Thank you so much. Enjoy your evening and see you soon. See you soon. Sorry.
Goodbye, everyone. Thank you very much. It's been a pleasure.
Thank you. Thank you so much indeed. Good
Thank you.
night.
Bye-bye.